Maybe what I could do is I could talk to you a little bit about why I'm here today in the first place. So I've always had an interest in machine learning and AI. I myself am a trained electrical engineer. And then after that, I wanted to apply my engineering skill into the biomedical field, more specifically into understanding brain, how it works. So I did a PhD in computational neuroscience and visual neurophysiology at the Montreal Neurological Institute. So essentially, I was recording from single unit neurons in the monkey's brain while they're performing a visual task. And I was trying to build the mathematical models to understand the underlying neural mechanism of how they generate the conscious perception of vision. After that, I went into medicine and I got into radiation oncology. So I completed my residency at McGill. I went to Brigham and Women's to complete the fellowship. I'm back here on staff in the radiation oncology department at the Royal Victoria Hospital, but I have a strong interest in particularly bioinformatics, the intersection of bioinformatics and medicine. And I also believe, I have a strong belief that AI and machine learning can really help us clinically to decipher a lot of things to discover and generate new knowledge, and also to help with workflow. So to this end, what I did is I'm taking a year sabbatical. I'm working part-time. I come back every Monday, and every time I have patients to see at the hospital. In my remaining time, I'm doing a master at the Artificial Intelligence Machine Learning with Mila. So while I was there, I was trying to see if I could find people to collaborate, to seek expertise in AI and ML, and to see whether or not I can integrate that into my clinical practice. So that's really today's goal, is not to give you a very deep knowledge of radiation oncology, but more just scratch the surface, give you an overview of what I do, what radiation oncologists do on the surface, and perhaps it can generate some ideas. If any one of you are interested in collaborating and perhaps joining force and bringing your ML AI expertise, but in the application of medicine, I'm definitely open for that. So thank you very much, Julian, for allowing me to talk. So really today's goal is to introduce you radiation oncology, the challenges that we face as physicians, and what my vision is as well. My vision is very well laid out in this consortium Medomics, led by Olivier Morin, who recently published with the group in Nature Cancer, a nice paper talking about how you can integrate AI and ML in the clinical workflow. But today I'm only going to talk to you about radiation oncology. So what is radiation? Basically, I use radiation to kill cancer. Cancer patient comes, there's 3 ways to treat them. Either you surgically remove the cancer, the tumor, you give them chemotherapy, and the third option is you use radiation to target the tumor cells, induce radiation DNA damages, and then the cancer dies by itself. So the most popular way of doing it is to use external beam radiation. So what you see right here is what we call a gantry. So it's basically a 6-ton machine, the equivalent of 6 Honda Fit. Turning around the patient with a millimeter accuracy, we can focus our radiation beams to exactly where the cancer is located. And that's how we give radiation using external beam therapy. There are different types and configuration of machines. One of the newest kit on the block is the CyberKnife. We have one here at the Royal Victoria. This thing is basically what you see in these car factories, how they assemble car doors together. Well, instead of the robotic arm, we armed it with a radiation cannon. So it shoots radiation beam at a millimeter accuracy, pencil beams really, all around the patient. And it even have the ability to track organ motions and to decipher real time where the tumor is exactly located in function of the patient's movement, breathing. So there's quite a lot of application for radiation oncology. I will talk about something brain pathology, just to give you an overview of the workflow, really an appreciation of how radiation oncology is applied to cancer patient. There myriads of common brain pathology that we use radiation to treat. They're benign, they're malignant. The one that I'm going to be focusing on today is the glioblastoma, because it's a pretty nice framework to talk about the workflow that we face. So typically, once you're diagnosed with glioblastoma, your life expectancy is actually really poor. We're talking maybe 50% survival in 12 months. With treatment, it can be a little bit longer, 14 months, and some patients actually survive long term. So I'll talk a little bit more about in detail how, why, and what radiomics or machine learning can bring into identifying these patients. When we have a glioblastoma patients, we usually go for surgery, and then it's followed by everyday chemotherapy and radiation therapy, 5 days a week for 6 weeks in a row, and then it's followed by another rounds of chemotherapy into week 30. So it's a really long treatment for the patient. Before I go into detail, how much time do I have actually, Jillian?
Let's say 20 minutes.
Okay, perfect. Okay, I just wanted to make sure that I have enough time to talk about how AI and ML can come in. So the workflow, to give you an appreciation of what we do when we see these patients, it's written here, these 5 steps that I'll go over in detail. Each steps could be aided by the AI community. So the first step is MRI and CT simulation. So basically, we have to acquire very detailed images of the patient so that we can plan radiation therapy. We know where the tumor is located, the areas at risk of tumor recurrence after surgery, after radiation, and we have to keep that in mind. More importantly, we also need to know exactly where the organs at risk are. So important organs that we do not want to irradiate. After we have acquired these images, we use fusion. So basically, we fuse every imaging modality that we have, PET scan, MRI, and CT scans, all of them together. Each one of them give us a little bit of information, different information regarding tumor locations and also where the tumor are at risk of spreading. Image fusion nowadays is very automatic. So basically, we just put the images together, and the software actually takes care of fusing all the image. That's really only recent that's been like that. In the past, it's not so straightforward. We actually had to move the images, translate and rotate them. We don't warp them. Contouring is a little bit tricky. That takes a lot of experience. So basically, what we usually do is we contour either the resection tumor bed or the gross tumor that we see. So the gross tumor is really what you see here called the GTV, the gross tumor volume. After that, we have to have a really good sense of the anatomy, how the disease and the cancer cells actually spread in the brain. I understand that your lab focuses a lot of imaging for the brain. So you may know these terms, corpus callosum or white tracts. Typically, that's where the cancer cells will spread. It's through these white tracts. So we have to add an expansion of at least 2 millimeters or 2 centimeters, sorry, because it's been shown that most glioblastoma multiform occurs within a 2 centimeter radius, but also from post-mortem pathology where we use histology slice of a diseased brain. We see a lot of cancer cells centimeter to 2 centimeter away. But drawing this expansion is a little bit tricky because there are anatomical barriers in which we know that the tumor won't spread. For example, if you have, if you're on the other hemisphere, usually you don't spread to the other hemisphere unless you follow the white track. So that is a little bit tricky when you contour it. You don't want to do a uniform QCM expansion because if you do that, then you'll be radiating a lot of brain tissue needlessly. Then we add other expansions called the PTV, the planning target volume, that takes into account the patient's motion and also our own machine's accuracy. Finally is the radiation planning. In the last 15 years, I would say, folks from the machine learning groups has actually helped us made a lot of improvement in terms of how we radiate the patient. It used to be that we would scan the patient using X-rays, and we would have the X-ray put up, and then we would kind of guesstimate where the tumor is located based on the other imaging modality that we have, for example, CT scan back in the days, and we would draw a target and we would say, okay, let's aim the machine right here on the patient's side, and then we're just going to blast radiation through and through. So what you see here is basically the lateral opposed beam of the radiation entering from the left to right and right to left, and a little bit from the front as well. Actually, nothing from the front. So you could see the red here is actually the tumor, and everything else is radiated as well. The convergence of these two beams are where the radiation is at the maximum, and that's how we target the radiation beam. These little triangles here are really lead blocks that we put in front of the patients, because there's a lot less separation when you go forward than you have in the back. So radiation tends to be a little bit stronger in the front end. So we just put lead blocks in front. So there's a lot of tinkering manually, and that's how we used to treat patients back in the days. But you can appreciate that there's actually quite a lot of those that are put into the optic chiasm, the back of the retina, the brainstem, in that case is the thalamus. These are things, and the optic tract, these are things that you don't, optic nerve, sorry. These are things that you don't need to radiate, but the technology that we have back in the days didn't allow us to spare those organs. Then came image modulated radiation therapy, where we put several beams. So already the radiation beam is a lot more conformal. And then nowadays what we do is we just span the whole gantry around the patients. And as the gantry is moving around the patient, there are multi-leaf collimators. So basically blocks on the radiation cannon head, if you will, that shapes the radiation output, so that when all of them converges, we could really give the radiation to that tumor that we want, while trying to spare as much as possible radiation from the other structures, in this case, the optic nerve. So the radiation planning this is not trivial. It takes around, in simple cases, 4 hours all the way up to 2 days to plan. Right now, it's still done. We have somebody actually doing the machine optimization. Basically, just they're supervising the calculation of the radiation dose and adjusting manually the weight sometimes to make sure that we have a good radiation plan. Complex plan can take up to 2 days. The other thing is contouring relies on the physician right now. It's not always very well delineated. Sometimes there are tricky cases where we don't really know where the tumor is located, or we sometimes miss how the tumor cells may be tracking and spreading inside a brain. There are software that allows you for automatic segmentation and contouring of the organs at risk. But really, the difficulty is really looking for the right target to radiate. And also analyzing the plan there are scripts that allows you to analyze plan. Right now, what we're doing is we're looking at these organ structures, and we're looking at whether or not, it's a very simple metric to see if they cross a dose threshold or a mean dose threshold. But there's actually a lot more information that these dose volume histogram can give and can be used for evaluation. But right now we're doing it based on a couple of data points only. So that's a dose volume histogram. So that's just an example of the organs that we're trying to irradiate the tumor, basically. This tells you that the volume up to 100% is receiving up to 60 gray of radiation, and then it falls off. Some of the other structures, they receive various different dose. The metrics that we used is make sure that we keep the radiation to those organs at risk of based on a couple of points, for example, a dose max or the median dose or the mean dose. But as you can see, there's quite a lot of breadth and information that clinically are not always used, but could be. Follow-up of these patients can sometimes be tricky. You treat the glioblastoma, this is post-surgical, and then this is 1 month post-radiation therapy. Sometimes the tumor looks like it's growing. This is a case of what we call pseudo-progression. So it's a lot to do with the tumor actually dying, apoptosis, and post-radiation effect causing inflammation. But if you follow these patients long enough, usually they can regress. So this case of pseudo-progression is always tricky because you cannot differentiate whether or not at 1 month post-RT, is it really pseudo-progression, or could the could the treatment to the patient have actually failed and the patient is actually having a tumor growing inside. These are important information that you would want to give the patient for the patients to either prepare psychologically or for management purposes where we could influence the treatment. Right now is it's very anxiety inducing because we have to follow these patients very closely, and it's not always easy to tell the patient, hey, don't know what it is. It may be progression, may not be, but we'll be following you. There are some scans, perfusion MRI, namely, that may be able to help us tell the patient whether or not it's true progression versus pseudo progression, but it's not always precise. So how can we improve? Earlier I said that there are long-term survivors. Some patients do survive long-term. For example, this. Turns out that these patients, likely what they have is that they have mutations to the cancer that they have, one of which is called a 1p19q co-deleted. You don't really need to know the exact genomic mutation, but what I wanted to say is that for some patients, with mutated gene, they actually respond very well to treatment and they could live a long time. This is where genomics comes in. When you start analyzing the gene of these patients, you could stratify them into different groups. It could help prognosticate the patient, but it can also predict treatment. Same thing for IDH mutated. I forgot to update my slide. This is not the right figure, but take my word. But the patients who have IDH mutation is actually a very good mutation to have. These patients respond to treatment, and they can they actually have a better prognosis as well. So the real question is, can radiomics do the same thing? Can we just use pictures, MRI, CT scans, PET scans, integrate all of them together, extract features, and then try to see whether or not it can help with survival? Or in the case of pseudo progression versus real progression, it's a real classification questions. You know, it's either 0 or 1. Can we use MRI signatures to be able to differentiate them? So in the recent years, there's quite a lot of publications that has come up looking at radiomics and see whether or not it can help. All I did here is just radiomics GBM on PubMed, and I was able to pull these, these histograms of publications in the last couple of years. The question of pseudo progression, I just looked it up recently, and that was one of the questions I was thinking about studying when I was in the residency. There are people who are looking at that, but the challenge is it's unlikely to translate to clinical use right now at the moment for several reasons. One of them is feature stability. Every group that look at the images will pretty much pull up their own features, and that's very much depending on the training data that they have and the images that they have acquired. It's not always translated into different groups and other groups in terms of what features they're able to pull up. There's a question of heterogeneity of imaging. MRI sequences are actually very institution dependent. Different institution uses different sequences. They don't have the same machine. They don't have the same setups and configuration. Interpretability is actually a big issue. For genomic expression, you send it to one lab or a couple of labs, and they will always be able to, with high accuracy, tell you whether or not a certain gene that you're looking for is mutated or not. It's just a yes or no question. But in terms of imaging a brain and then pulling the features out, gradient descent or whatever you want, it's really hard to tell a clinician, hey, these are the features that are most correlated with survival or recurrence. So when you cannot interpret what you're seeing, it's really hard to convince clinicians to change their practice. Field experts, you actually have a lot of genomic experts, assisting clinician when seeing oncology patients. We don't have the same type of expertise. We have physicists who works with us mainly to commission the machines, but in terms of guiding clinical practice with radiomics data, for example, it's not something that's very common. Of course, one big thing is pharma funding. When you have genes that is mutated, you could exploit that gene using drugs. And the pharma company, whether you agree with it or not, they actually make a lot of money from that. So they have an incentive to fund research that looks at mutation and that looks at targetable mutation, more importantly, so that they can develop drugs. And finally, it's lack of high-level evidence in clinical trials. The reality in oncology is that we follow the highest level of evidence to guide our treatment planning. We often talk about level 1 evidence, which is randomized controlled trial, or meta-analysis of several trials together. And these are really how we guide our practice. We look at these randomized controlled trial, what they've done, what are the patients that are included in the trials, and what were the outcome. That's how we guide our practice. A lot of the work that we do in radiomics, for example, unfortunately, is retrospective study. So we look back at the patients, the outcome is already there, and we look at what are the features that we could pull, and can we do a classification exercise on them to see whether or not they're most likely to respond to a certain treatment or not. So that's really the where we are at right now in terms of radiomics. Lots of retrospective cohort studies, lots of case series, but none who really integrate radiomics into comparative study in phase 1 or phase 2 trials. Definitely no phase 3 trials on that. But there are other areas where ML can come in, and this is going to be my last slide. So operational workflow, I talked to you about the contouring part. There's a lot of auto segmentation, but there could, there are room for a contextual auto segmentation for the clinical target, the gross tumor volume and the PTV expansion, where machine learning can help, in the context of knowing the brain anatomy, for example, know where the white tracks are located. We could use those information to aid for expansion of tumor volume, for example. Radiation planning is another area where you could have a lot of AI and ML come in and help us. A simple case can take 4 hours to plan, a complicated one can take up to 2 days. And a lot of the work is really somebody sitting in front of the machine and playing around with the weights and constraints, and running the model again. To treat or not to treat is often a very difficult question for me as a physician. I see patient, if I don't look at the patient in terms of the clinical performance, and I just very simply put the patient, stratify them as their presentation, their age, their histology, it's easy for me to say treat or not to treat. But in reality, there's a lot of variables that comes in. Patient can be sick, patient who have different values or different goals of care. Or when they're extremely sick, I'm not sure if my radiation can actually help the patient, or will my radiation actually make the patient sicker and thereby unable to benefit from the radiation. In those situations where I'm already making a decision on treat or not to treat, I can think of different ways of medomics could come in and help us decide and finally make the call and say, look, based on the information that you may not automatically decipher or digest because there's just too many. There's a likelihood that the patient may benefit from treatment. In that case, it may tip my decision toward treating as opposed to saying, I'm sorry, I don't want to offer you any treatment. So that's a very, very, very brief and high level bird's eye view of radiation oncology. Again, my goal is not to give this talk to experts in radiation oncology, but it's just to give you an appreciation of what we do and perhaps inspire some ideas that you may have. If you do have ideas, we could always, I would always be happy to discuss possibility for collaboration.